So it's in, infant mortality. So even though I talk about infant mortality, death of an infant is very little to do with the infant and mostly to do with the health of the mother. So that's why it is about women's health, that a lot of this talk is about. So infant mortality is a measure of both the upstream determinants of a woman's health as well as the services that you offer. And I think these are the key slides. So Birmingham and Solihull has the highest infant mortality in the country. And that has been the case for the last 2 decades. So I'm not sure how many of you knew this, but for 20-25 years, we have topped the nation in the life expectancy of our infants. And then, this red rectangle probably tells it all. This gray line is Birmingham and Solihull. This red dashed line is England. And this is West Midlands. So I was at the national meeting yesterday. Even our neighbors who are 2 and 3 in ranking are so much better. So the gap, Stoke-on-Trent is the next and then Leicester, but the gap between Birmingham and Stoke-on-Trent itself is so wide that it doesn't bear talking about. So it's just to say that the problem is sustained, pervasive, and quite significant. So that's that. So this is the decade-long thing, So if you look at 2010, this is us, and nothing much has changed. Everybody else has stabilized or become a bit better. Anyway, I won't elaborate the point too much. You understand the point. And I guess the other thing for those of you who work with global majority communities of deprivation is the slide, So this median white British data of 3.9 babies dying is nothing aspirational. England is one of the worst countries in Northern Europe in infant mortality. So you're starting from a very, very, very poor baseline. So this 3.9 is nothing to write home about. So from that poor baseline, Pakistani community, the Black African community are around 3 to 4-fold the death rate. Okay. And similarly, if you work with communities of deprivation, if I live in a least deprived community in Birmingham and Solihull, my rate is very similar to that of Norway and Finland, who are, one of the best performing countries. Whereas if I live in the most deprived, my chances of infant death is around 4-fold. Okay. And I think the reason I present these statistics is, whenever we partner with community organizations for interventions, one of the criticisms for you is that what are the metrics to show success or failure of your intervention? And I can support you with as much data as you need for the localities you work in. So I've got this data broken down into each of the 5 localities in Birmingham and Solihull across a lot of the domains. So, in terms of writing bids and those types of things, whatever pre-intervention data you need, I will supply you with that. Then I think, why babies die and also I'm going to stop, a lot of the deaths are in the first month. Again, all the more reason to say a lot of it is about maternal health. Very few babies die after, the first month. A lot of the reasons for the death is extreme prematurity. And that is very much due to maternal diabetes, maternal obesity, maternal smoking, teenage pregnancy. So again, there are a lot of modifiable risk factors as a community or a neighborhood that community organizations can work towards. Congenital anomalies is a thing. Usually when people, again, and I will speak openly, usually when people, talk about Birmingham, they'll feel, it's congenital anomalies because of our particular demographic, However, a lot of the congenital anomalies is also because of poorly controlled diabetes, poorly controlled obesity, also play into it. So it is not just a demographic related congenital anomalies also, So I guess, then it's an intersectionality of a number of things, deprivation, teenage pregnancy, obesity. And I think this last bit about accessing antenatal care. So I'm a part of the ICB. I work with the local maternity and neonatal systems. So again, we have data that looks at, if you're pregnant, you need to book before you're 10 weeks pregnant. A lot of our vulnerable communities, whether you live in an asylum center or whether you belong to a North African community, you very often see a pattern that they book pretty late. So some of the statutory partners are looking at community partners who can support women in seeking medical health, access, getting access at the right time, empowering them. So these are just threads to explore, a teenage pregnancy. If some of you are working in that arena, obesity is critical. Weight management and exercise and activity is critical. If you have diabetes, if I could pick out 2 or 3 things, the things I would say is preconception health, optimizing preconception health in men and women. And I think the important thing is not to leave the men behind, because you see, if you're not pregnant, it is 2 people before you get pregnant, so planning your pregnancy, so those things. And then once you are pregnant or before you're pregnant, managing your diabetes is a critical modifiable risk factor. Managing smoking is a critical risk factor. Getting to your appointments, is a critical modifiable factor. But anyway, and then once the baby is born, maybe breastfeeding, immunization, those types of things. It's important to know what is a transactional thing that you can all be part of. So one of the other things we created, because you see, always a lot of interventions are best done upstream, before you're pregnant. So this is a thing for before you're pregnant, So if you are a man or a woman, or man and woman, between the ages of 15 to 45 in Birmingham and Solihull, what we co-produce with a lot of community partners is this document called Bump Ready. It's got 3 messages, plan your pregnancy, because if you do not be pregnant, if you're not ready to be pregnant. So the first bullet point, as you can see, there is plan your pregnancy. Anyways, make it a bit bigger. So the first is plan your pregnancy. And the second is, if you have then decided to be pregnant, prepare for a healthy pregnancy using top 10 tips. Now I'm just going to scroll right to the bottom to show you what these top 10 tips. So it's a leaflet. It's also coming out in an animation. It's there in the 10 different languages in Birmingham and Solihull. And if I can just find. So this, so for those of you who work with youth groups or young men and women, it comes in a very clear top 10 tips, And I guess even if I just picked out one of these top 10 tips, if you take folic acid before 3 months before you're pregnant, your chances of having a baby with no brain and spinal cord defects is increased by 85%. If you do not take folic acid, you have considerable risk. And this is before you're pregnant, 3 months before you're pregnant. So a lot of the community sessions where I go, the young people will say, we have never heard of such a thing. Why was this not told to us ever? We didn't know you had to take it before you're pregnant. So it's things, so there is a very transactional intervention way. I would say, if people who work in youth groups or people who work with mothers who are pregnant, between pregnancies, this Bump Ready is a good intervention if you can share it in your communities and get people to take it up. Folic acid costs £1 for a month's supply. And then I'll just do one more sharing of just to show you what sort of data is available that you can then we will open it out to discussion. Just some locality data, because you see that then is helpful. So, so we looked at all of this data for each of the localities. I haven't gone into granular data around neighborhoods, which I guess is probably relevant for you. But, so don't worry too much about the business of the slides. But, things like, say, if I highlight something BMI of, or say teenage pregnancies, so 2.4 in the north, 4.1, whatever. But I guess it's things like, what is my obesity rate, and then we looked at what's the folic acid uptake rate in certain localities. So, surprisingly, Solihull is low, 74%, 69% in East and all is pretty poor, So similarly, gestational diabetes. This is one of our biggest risk factors, that women who have gestational diabetes neither attend antenatal clinic appointments, nor do they attend appointments after delivery. So just to generate some thought about where are the areas of congruence for you guys. And then similarly, type 2 diabetes. If I have type 2 diabetes and I'm pregnant before my diabetes is controlled, my significant chances of adverse outcomes are very, very significant. So there is all this data, that we can give you if there were projects that relates to these things. But anyway, I think, so these were the things that I wanted to say and to see if any of these had any synergy with any of the work you're doing. If so, I would be more than happy to support right joint applications, whatever. Neelam, spot on the money is what I would say, all the things that you have said. And I think particularly, this gestational diabetes thing, I'm a pediatrician. My heart sinks when I sit around in these meetings. And just for all of you to know, if I have gestational diabetes, I have 50% chance of developing type 2 diabetes as I go on. And I'm meant after delivery to have a 12-week blood sugar check. I am meant to have a HbA1c annual check done. I'm told by all the health professionals that it's all there in the discharge letter. There is a National Diabetes Prevention Program lady who says it's there in all. However, I don't think any of the service users have heard any of it. So if you say you don't know where to start, I guess Benita and others are here. Rosie is here. What's a sort of project? So we have a diabetes care pathway going. And we have done a diabetes leaflet also, and this leaflet will be ready to run, so you have an actual finished product which is co-designed and co-produced with your communities. So I guess a starting point would be to say, how can I disseminate it? Who can we train to disseminate it? Where are the forums you can disseminate it? There is also a diabetes preconception leaflet that has also been co-produced. So I guess maybe the steps would be to discuss with your champions like Rosie and Benita to see you have an idea, a germ of an idea, how can it then be developed? Because see, the beginning point is you have a group of service users who do not have a lot of information. So then to get it from here to here, where I have the information would be a first step. So then I think you look at the process steps and look at the gaps and identify a journey is the way I would look at it. But while I'm not promising the world, what I will say is, I think Neelam and others, so there is an MNVP, group now, and the expectation from the MNVP is that there is a bit of a feedback loop about, so you said, so what, did anybody respond to any of this? So there is a little bit of some sort of a circular loop where people do respond to some of these things. And sometimes times change. Maybe it is getting a critical mass of people who have the ambition and the investment to move this forward, particularly in diabetes. We have set up a diabetes care pathway with very committed diabetes clinicians and others. So maybe from 9 months, maybe something is moved on a bit. But I guess we will have to discuss each thing on a case-by-case basis. And I guess each of these projects at the end needs to have a sort of exit interview type of thing, isn't it? About what worked, what didn't work, and what can be learned from things that didn't work. So I'd very much welcome a conversation so that we don't make the same mistakes again, Shaban. I will say the NHS in Birmingham and Solihull particularly faces a lot of challenges. I've done around 30 listening sessions with men and women across Birmingham, across all ethnicities, all type of denominations. And universally, you hear, a lot of concerns about the NHS, and that is important to hear and respond. So that's okay.
The Fairer Futures Fund, locality small grants. And so the locality small grants is about doing something within a neighbourhood, a constituency, or a locality, which is two of those adjacent constituencies, doing something to address one theme and priority. And I'll just show you what those are in a second. Everything is on the Heart of England website. And the support at this point in time in terms of unpicking and looking at projects and getting advice, etc., is with the neighbourhood network schemes. And you can't submit, there's no point in submitting a project until you've spoken to a neighbourhood network scheme. But essentially this is three years worth of funding to tackle a single health inequality at £15,000 maximum a year. So you could be doing something in one community, you could be doing something across a few, you could be doing something small, something up to that 15, you can do it for 1, 2, or 3 years. The information's here, and the bit I want to just pay attention to is in the application guidance where you have all the slides which tells you who can apply, you know, who the leads to contact for the neighbourhood network schemes. And then it's got the 4 areas of priorities. And what we're talking about today is the priority of best start in life.
I mean, I think those themes are aligned, isn't it? So, the women's health, the infant mortality straddles all of those three blocks, isn't it? So whether it is young adults or whether it is women accessing care, whether it is improving health before they're pregnant, East and West are the worst off. But then you see, in terms of priorities, infant mortality is one of the 5 priorities for the system. It's all ICB's 10-year strategy. Infant mortality is one of its 5 priorities. So I guess if you wanted to put in reasons why you've chosen it, there will be enough statutory reasons. But anyway, I'll stop and wait for any questions or themes that occur to you or how we can support. I'll also say that the maternity system bump, so they do have maternity link support workers. So if you're looking at statutory partners to help you, I think the MNBPs are also a good way to get your messages across if partnership working isn't going well. Public health. So the other thing I wanted to say is I work closely with public health. A lot of this work falls under the remit of public health, and partners in public health also, I have said they need to work closely with, colleagues like you. So let us see. So there are statutory partners who have said they will try and work closely with you. Maybe not in delivery particularly, but at least in getting a bit together and making sure they partner equally with you. And I'll also say one more thing. There is a thing about, something called proportionate universalism where you give all interventions to everybody, but then you see, you drill it down to say, we clearly know that there are vulnerable high risk cohorts, whether from that data, if I said, okay, the Black African population is high risk, you can still justify how you then drill it down. If narrowness and crystallization is what the funders want, then you would crystallize it down and say, well, the data actually shows, although the whole of Birmingham is generally vulnerable, there are pockets and groups we work in who have greater degree of vulnerability. So we will narrow it down to, a part of East Birmingham or a certain community or migrants, or, that fits in with the core 20+5 agenda as well, isn't it? So depending on your capacity and scalability, you can make it whatever it is. But I think it is seeing a cogent, doable delivery plan that I think presses the buttons. For South, I think for them, they feel in maternity, South is one of the better localities. I think generally so, but however, for you, Edgbaston has very poor outcomes. When I look at the actual number of infant deaths, again, I have to say, then they question the statistics and say we don't quite understand how Edgbaston can have, So I met with, what's his name? Your Age UK chairperson. I think I met with him. But anyway, so I guess so in answer to your specific question, is it best to focus on outcomes where you have poor? Yes, I mean, naturally, that would be what people would want, number one. And my message would be, if the whole of Birmingham is having this level of, highly unacceptable outcome, maternal health has to figure there. So that was my first message to Age UK, number one. So I think they've taken it on board. In terms of the specific projects, Madeline, I think it very much depends on what your area of work is. I asked, if you work with youth, if you work in schools, if you work, then preconception, health education and health promotion would be a good thing to say, okay, because of our intervention, the statistics at the other end is more people took folic acid a year later when they booked in at maternity, So it might be that you say preconception, health education as a whole among the communities you serve might be a good thing. Then the other thing where it's probably not good is early booking to maternity. You might then say, okay, we partnered with the BUMP maternity link support workers in South. That's a project that we can deliver, that everybody books early. Immunization, vaccination, and breastfeeding are such wicked problems that there will be enough statutory partners to partner with you. If you say we will try and help improve uptake of immunizations, then this maternal diabetes is a specific project. If we say, okay, all the women in South with gestational diabetes, we will make sure we will work in partnership with GPs or the diabetes pathway, which I can bring the partners to and say we will try and get them to their appointments on time. So I think, Madeline, yes, most areas have specific poor outcome areas to focus on. So yes, those would be the areas to focus. But then it's also got to be aligned with your strengths and the communities you work with. I just come in there, Narina, and thank you. And I guess I think you make an important point though, because you see, when you say it's about raising awareness, and I think there has to be a question at the end of the raising awareness about, so what? Leaflets don't change lives, actions change lives. I can do as many leaflets or animation as possible. People will put it in the bin as they walk out of the door, and I think that's why I'm a bit curious, as an organization like yours. And if you say Iron Lady for South Asian, I cannot think of anything more pertinent, because I think the thing you need to hear, there's a lot of statistics. I didn't want you to sort of depth by statistics, but I'll tell you, 1 in 2 women have morbid obesity when they book into the maternity system. So BMI of 30. BMI of 30 is just obesity. BMI above 35 is severe morbid obesity. In Birmingham, 30 at 30. So overweight is 30, obesity is 30. 60% of women who book to their first pregnancy booking, 60% fall under overweight and obesity. Of that, the predominant groups are the Black community and the Pakistani community. Therefore, everybody gets type 2 diabetes, therefore, or GDM, and therefore the outcomes are poor. So, how it cannot be seen as a priority and you've been directed to something else. And this is why I say what is not visible for me, it is not visible. Maybe other people have greater problems than I do. But I think that's the figure. 67% of women are obese. So I think, once you give them this leaflet which says eat healthily, this, that, and the other, they actually need somebody to help them. There's no point telling me lose weight, isn't it, if I don't quite know what to do. And one of the other biggest thing, there was a big study from the University of Birmingham, just concluded recently, where it does say, you can help women lose weight by communal activities, and particularly, women from deprived backgrounds and others who don't have the confidence to go to places. If you would arrange a communal thing, less online and more physical, and if they could bring their children there, then they would participate, and therefore your gestational weight gain can be reduced. So anyway, so I think obesity, whoever can take it up, it would be good, even if it's in a small pocket, to say this is proof of principle that this model would work, particularly in, women from poor backgrounds or women from global majority backgrounds, or even diabetes. One of the things we were looking to see is, would you reduce the prevalence? So, for those are the sort of things where we can give you the statistics before and after, about did the GDM control become a bit better because they exercise during pregnancy. But anyway, good luck, everybody. I hope whatever you're applying for succeeds. But do, let me know if I can help in any way. Thank you all.